Well, first, hi, my name is Tyler Lawrence, Chair of the Families and Health Special Interest Group. It is my pleasure to introduce to you our guest speaker today, Dr. Hernan Berenboim. Dr. Berenboim joined the KPC group as the Chief Diversity Officer and Psychologist faculty in 2022. He was born in Buenos Aires, Argentina, and after moving to the US, he completed a PhD in medical family therapy at St. Louis University, and then a fellowship at the Chicago Center for Family Health. He has more than 20 years of clinical experience that includes psychotherapy to individuals, couples, and families, supervision of mental health students, and teaching behavioral science to family medicine residents. Without further ado, give a warm virtual welcome to Hernan.
Thank you, Tyler. And just to mention that Tyler and I were buddies during the PhD. And so it's double fun for me to be here again in CFHA and also to be invited by Tyler to conduct this workshop. So what we are going to talk today is something that I don't know why, but it's not such a common subject. That is psychotherapy for medical providers or medical professionals. I am not a big fan of the word providers, but it's it's not a subject that you can hear so commonly. And I think that is in big part in the same way that we have a lot of stigma in society for around mental health in general. We are going to talk that actually in the medical community is even more common. And this stigma is based in different things and different origins, why people is not so prone to go to psychotherapy even when they really need it. So let's start. I call the webinar Medical Families at Risk because in my clinical experience, since I started working in primary care, since my time in SLU, and actually even before in Argentina, I saw that there is a heavy individualistic type of perspective about psychotherapy, and more in the medical community as well. So since I am a family therapist, by training I am a psychoanalyst, but since my PhD in SLU, I changed my perspective to be much more working with couples and families. So I try to involve the perspective of the family in these medical families, because I saw that actually when you have a doctor in your life or in your family, the implications of that is not just for the doctor, it's for all the family. So let's talk about that. I cannot see the faces of all of you, but if there is any question or something, please just interrupt me. And Tyler, if you want just to tell me that there is any question in the chat or something like that, I am happy to just stop and answer the question. Okay, guys? So what are the objectives for today? By the end of the presentation, participants will be able to list common personality traits of physicians, spouses, and children, describe 3 family therapy techniques to run psychotherapy sessions with medical families, and finally, analyze a clinical case and propose a family-oriented treatment plans. So can you hear me okay, Tyler?
Yes, beautifully.
Okay, perfect. So the term medical families is not such a common term. It's not that in the literature, or if you do a Google Scholar search, you are going to find tons of papers about that. So basically, it's kind of an informal term that is used in some parts of the medical community. And in the AMA, for example, they have a group that is Physicians Wellness, and one section of these groups is about physician families, and they call the group Family Commons at the beginning, a couple of years ago, and then during the publications that they have and the magazine that the AMA in Wellness for Physicians, the Physicians Families magazine, actually you can find this term, but this is not the term that if you Google it in Google Scholar, you're going to find it very easily. So basically, in my perspective, medical families and families where at least one member is a physician. So there is not so much research about what happened with the families. It's not a surprise. Something that is interesting is that there are a particular family dynamics. It's not that these families are, for a lot of therapists, when these type of families come to your office, you are gonna find that to understand the medical culture and what's happened with these families is not so easy. There are a huge financial factor, and there is a society prestige that actually these two final points are very related to each other, because we believe that doctors in one way or the other have a lot of privilege because they have high salaries. And this involves a lot of prestige. Yes, that is true, but this comes on parallel of a lot of cost, as we are going to talk in a couple of minutes. So just to understand a little the case that we're going to talk about today, this is the family where actually, if you see this genogram, okay, the identified patient is the daughter of Ada. Ada is an ER doctor, an emergency doctor that is married to Chef. Chef is an ex-CEO of a company. He was extremely successful, very, very successful, until he was discovered to have multiple affairs with a lot of subordinates in his team, in the last company that he was working for. And there was an HR investigation about that, and finally he was fired for this company. Since then, he took the role of being the dad's at home, you know, so basically he was taking care of the family, the caregiving, the housekeeping, and most of the things in the family, at the same time that Ada was still an ER doctor. The call that I have asking for psychotherapy was from Chef, and he was basically asking to have psychotherapy for Joan. Okay, Joan is the last daughter of this family. She's 15, and she was having a lot of problems in school, isolation, very reactive in the family, and very emotionally disconnected for everyone. Even that she used to be very close to Chef, at the moment of the psychotherapy, she was not. They have two other children, that they are Miriam and Mike. Mike is a recent lawyer, and Miriam is also a doctor. Ada's father used to be a very successful surgeon, Theo. That he was alive at the moment of psychotherapy, and he was around 86 years old. And Ada's mother is Mona. So we can see here, just in the right line, okay, that we have something that is happening in the different generations around professional work. On the other side, on Chef's side, both of the parents were dead, and something important to try to understand since the beginning is that they were immigrants from Germany, and Jeff said a lot of times that the emotional connection with the parents was not easy. However, each time that he was talking with about his parents was very, very difficult for him to do it. And to the point that sometimes I have to take him out from the family therapy and talk to him alone just to regulate a little his emotions, because he was extremely sad all the time that we were talking about his parents, even that they died several years ago. So a question for the group, you know, and you can write it in the chat, or please just put your mics on. When we come back to the genogram and try to think in the right part of the genogram, okay, in Theo, Ada, and Miriam, what factors take your attention? Think about generational patterns and genders related to medicine. Please tell me, what are your thoughts? What do you think?
Could you go back one slide, Hernan?
Yep. Try to think in the three generations, and what profession do you see more than any other thing in the genogram? Okay, yes, Amy, an expectation to be a physician. Of course, this is an excellent point. Yes, families of physicians in general terms, you are going to see that generation after generation, you are going to have more, these families are more prone to have another physician, okay? In big part is because physicians are inside a culture that is not so easy to understand from people outside the medical culture. So when you have a physician in the family and some work is done around the medical culture inside the family, you are going to see that it's easier in the next generations actually to talk the same language because it's the same cultural factor. And in terms of genders, something that is important, I'm going to talk more about this in a couple of minutes, but something that happened about gender is that now there is a feminization of medicine. At this point, we have, for first time in the history of medicine, since a couple of years ago, we have more female medical students than males. Still, there are a lot of problems around that, but yes, it's a tendency that is happening. So families of doctors generally share a traditional sense of the cultural factor to be a doctor for the medical culture, and also doctor parents are prone to have doctor children, okay? So the first session, mom got 15 minutes late due to an issue in the hospital. Father, brother, that is the young lawyer of 24 years old, 25 years old, and Joanne, that was the identified patient, were in the waiting room. After I saw that at minute 12 that Ada was not there, I asked them if they want to reschedule. And Joanne said, this happens all the time, just let's wait. Father, at the moment that we went to the room, father did most of the talking when we went to the room. The patient's problems with school, friends, and family were the most common themes that happened during this meeting. And the identified patient, that is Joanne, she was not very comfortable that they were talking about her, but she refused to talk. Even that during the session, at some point, I tried to speak with her alone. Took me some time until I could develop some trust with her, and during the first session really was much more of the talking, the parents and especially the father. I explained my no secrets policy because at the end of the session, Ada was very emotional. Ada is the doctor again, and I explained my no secret policy, and we scheduled a time to have an individual session with her. In the individual session, Ada describes her family as a mess. She defined her life as a perfect storm. She said to feel guilty and to when she's in the hospital to feel that she was not a good mother at home. And when she was at home, she was feeling guilty for guilt and some shame also for her partners at the hospital in the ER. At the moment that we have these sessions, there are always shortages in healthcare, we know that. But at the moment of this session was a particular moment of shortage in her ER department. And since she was one of the most senior doctors in the department, she was working almost 70 hours a week. But this was not something that was so uncommon. And of course, that if you work 70 hours a week, at some point it's because you are on call and there were not so much time for sleep. So what thoughts you have, if you just give me one or two, sentences of this second individual session with mom, with Ada, try to think in, this thing that when she was in the hospital, she was thinking about what was going on her house. And when she was with her family, she was thinking on what happened, with the hospital. Exactly. Feminization, Amy, good. Yes. Work-life violence, yes. Ada feels tension between family and her profession, of course, yes. And feminization of of medicine is bringing a huge challenge for female doctors. We have to remember that in traditionally, white males were the ones that they were doctors and more in the family, in several specialties. And these white doctors, they have some privileges because they were working a lot of hours in the hospital, but all the family life was handled by the partner that generally was the female spouse at home that was not working. When females now are working, to have some balance about family and to have some balance about work is almost impossible. Why? Because the medical culture requires a lot of hours of work, and families, of course, that also require some stuff happening in the family, more with the central role of women. So what we're seeing is that actually the women can be really stressed out when they are in medical settings. Yes, Laura, I generally feel like most moms in workplace feel the same tension. It's an epidemic in many professions. Definitely, I agree. I agree. The level of pressure that now we are putting in women in terms of keeping the traditional role at home, and on top of that, being, leaders in healthcare is just, at some point, this system, I think, that has to try to think in some options to change that, because it's extremely difficult. So in 1990, 20% or more of females, from 1990 to 2018, there were 20% more females in going to the medical field. Since 2017, the number of female medical students is higher than men. And this is going to bring, I think, that at some point health systems have to change and start thinking in new strategies to keep more doctors, because we know that also there is a huge, a lot of doctors are leaving the profession. So physician women, several more demands than male physicians: family planning, pregnancy, raising children, work-life integration, significant equalities, basically because still, when a woman is with traditional male guys and meetings, they are often, targets or diminishing the messages or microaggressions or some biases. So still is like the respect that still women can have in the medical field is something that we have to work on, because if we want more women in the medical field, of course that we have to make the conditions of work a little more humanistic. As a result, female physicians suffering is in silence. And let me show you a very brief video about what's happened a couple of years ago.
A bill aiming to provide mental health resources for frontline workers is one step closer to being signed by President Biden. Late last night, the Senate passed the Dr. Lorna Breen Healthcare Provider Protection Act. The bill was named in honor of Breen, who took her own life last year in Charlottesville after struggling with mental health issues stemming from the pandemic. Senator Tim Kaine says the bill has support from both sides of the aisle.
I'm very emotional about this bill. I have a hard time talking about Lorna, who I never knew, but I've kind of come to feel like I knew her. But what makes me particularly emotional about it is the conversations that I've had with healthcare providers all over Virginia.
The legislation would promote educational training on mental health and best practices to prevent suicide. Kaine hopes the bill will be signed by the House in the near future. A bill aiming.
So what we see is that doctors are the third profession in the States with the most quantity of people killing themselves each year. And women are around 3-to-1 ratio more prone to do it than males. So another unique struggle unique to female physicians is breastfeeding. Yes, definitely, Laura, I agree with you. One of the big problems is that when physicians have babies, where we are going to give some space for them to take care of the kids and also to feed the kids. So some organizations are a little more sensitive to that. but still there is a lot of work to be done. I definitely agree with you, and there is, yes, some research done that, with all of these feminization of medicine, this is going to bring new rules to the game. And I am very, I wonder how the system is going to make all of this happen in order for us to have doctors, and we need doctors. So it's going to be a very interesting, debate that I expect to happen in the next years. So in the third session, I did, because I am a family therapist, we know that always there is an scapegoat in the family. I really think that the 15 years old Joanne identified patient really was not such of a focus of everything that was going on in the family. So basically, I didn't want her to think, Joanne, the teenager patient, that all the problems were her. So since I had an individual session with Ada, the doctor, that this was the second session, my third session was invite both parents, because since I discovered that there were some infidelity in the family and a long history of discord and some problems between the relationship of the parents, I really thought that the parenting session was going to make more sense before going to the family setting again, than to have more individual sessions with Joanne, or to go to the family setting, to the family dynamics without going to the parents dynamics first. So they met, Chef and Ada met when she was in residency. At this point, Chef was in his first position as a CFO in a big company. After 3 different positions as CEO, he was fired for legal problems for having sex with several subordinate females in her team. Since then, he defines himself as a home dad, to take care of the children and save his marriage. They didn't do any marriage therapy before. They have a very hardcore Christian-based belief system that was we have to, I don't want to go in this direction so much, because my idea is to talk more about what's happened with medical families, but this was a huge during the first session, we have to talk about the Christian beliefs a lot, because they were having some problems with their own families around going to therapy, but at some point we could decrease the intensity of this shame of coming to therapy when they started seeing that this was helping them. So they didn't have any intimacy for the last 3 years when they come to psychotherapy. And there was an important decline after the discovery of affairs from Ada. When we were talking about the affairs, something interesting in Ada was that she was not having any type of emotional reaction. She was talking about this like nothing. Chef does not believe family's a mess, as Ada believed that. And he thinks that she's not so much at home to evaluate if the family is a mess or not. Both of them came from families where moms stayed at home as principal caregiver figures. Most infidelities happen during the transition from residency to a full-time to the emergency first full-time job that Ada has. So this is another question that I have for you. Why do you think that most of Chef infidelities happen during first Ada full-time position as a physician?
This is Samantha. I was probably because she was gone more and maybe more distracted at work. So maybe he felt like that, like he felt a need to seek intimacy outside of the marriage.
Excellent point. Yes, there are a lot of times of isolation. Thank you, Samantha, for that. There is a lot of times of isolation in partners during the first-time job, more because, it's a huge investment to go with someone during residency time, and it's a huge investment to go with someone during medical school. So a lot of partners believe that at the moment that there is the first-time position, everything is done. Okay, these partners are not part of the medical culture. They actually don't know that actually the exigencies and the amount of work that is coming is actually more than before. So there is in the contract, in the implicit contracts of most of medical marriages, there is this idea that in the first position, oh, everything is going to be better. And most of the time it is not. So let's see what else we have here. Tina says it is not right, but she was focusing on work. Yes, very true. Doctors, we are going to talk more about doctors, but we have to understand that the medical culture don't allow people to think too much outside the medical culture. So did she have infidelity also? No, she didn't report any type of infidelity. And actually, she described herself as not as a sexual person. She could develop some good intimacy with chef when she was in residency time, but after that, sexuality and intimacy went down a lot. So Amy says, perhaps he was seeking validation from others, giving her role success as a physician. Yes, exactly. Both of them were coming from very traditional white Christian families where the idea of the female at home was something that in the generation of Ada was broken. So in one way or the other, for the chef, his role as a male provider was on check. So yes, all of these were really good points. Thanks for the feedback, guys. So the significant other, when we think that just doctors are burnout in more than 63% of the cases, you know that today 63% of doctors are reporting or high levels of stress or burnout. And actually, if you take them and you make just a brief assessment, I don't think that you are not going to find the stress in any doctor that you can treat today. So, but actually burnout is not just for doctors, okay? 30% of couples of doctors also report burnout. They feel that sometimes they are invisible, sometimes they feel lonely, they feel that there is no couple time, they feel that why I have all the caregiving responsibilities, and finally, the housekeeping responsibilities. So Laura said, I would wonder about depression for her, giving her decreased libido and increased emotional numbers. Likely, he was unable to connect with her as well emotionally or sexually as a result. Really good point, Laura. In my experience, I think that there is, what we know also for research, but there is a huge connection between depression and stress. And since it's really difficult to find one doctor that doesn't have a good amount of stress, you have to always assess for depression because it's very extremely common. So yeah, there is a big possibility that Ada, the stress level of Ada and her depression were also in connection to the lack of libido. So something that we have to think about medical marriages. We have to define what is support, okay? Most of the significant others of doctors don't sign up for the level of support that to have a doctor in the family means. The life of doctors is not their own. The life of doctors are healthcare systems, because healthcare systems, our patients really take most of the life of doctors. So when they go home, most of the time, it's kind of a reconnection of what's happened during big part of my life, and then I go home. So, support means, to understand this moral standard that most doctors have about the profession, okay? When I talk about the moral standard is because, doctors are a huge part in our community, in our societies. Without doctors, there is no society that can work. From the first, if we go to any type of book of sociology, we are going to discover that one of the first professions that happen, or professions or occupations or whatever you want to call it, in any society, in any society that is developing, is someone that is the healer. The healer can take different names, in the last more Western type of history, we can find the term doctor, but can be a healer, can be a shaman, can be someone that actually takes care of what's happened with health. And we have to understand that the goal of taking care of others, this vocation of service, this goal of I'm gonna serve others, is a huge, there is a huge moral implication of that. And if the family of the doctor, if they are not part of the medical culture, you know, they don't know about this, and they are not aware of how is the importance of a doctor's life in a society, or they don't share these values. Most of the time, what are you going to see is a lot of conflict. Okay, this is very different when you have two doctors in the family. When in the couple both are doctors, you're going to see much more empathy, you're going to see much more understanding. Why? Because they understand what is going on with the other one. Okay, but when the partner is not a doctor, at some point there are always fantasies, questions of why you need to spend so much time there and you don't spend so much time with us. So still today, there are contradictory findings about divorce in physicians. Some research is saying that actually physicians' divorce is higher than regular population. Some other research is actually saying that it's lower. But something that, yes, is a pattern in most research that I found is that there is satisfaction problems in the couples of doctors. Most of the time, the family or marriage satisfaction is not so high. So as I said before, when both of doctors, there is more empathy, there is, you know, more understanding of nights in the hospital or being on call, or, you know, spending more time with the cell phone than with the family. And at some point, you know, in the families of doctors, this become the norm. When this is the norm, it's not, this never implies the same level of conflict than when people that is not so much part of the medical culture. So in the fourth session was Chef, Ada, Joanne, and Mike. After the last session that I did the marriage counseling, I felt that we were ready to try to attend a family meeting. So all of them came with the exception of the OB physician that also was, at this point, was not living with them anymore. So there were new problems at school. Ada was very critical of Joanne. So this is the first time that Ada was showing, you know, really an emotional content besides all the logic, where she was always, most of the time, talking with me. And Chef was trying to decrease the conflict between Joanne and Ada. So children of medical families, they are high achievers, okay? Doctors are high achievers, and they are very competitive and very successful 99% of the time. So in general terms, these achievements of parents is a model of family, and children most of the time are very connected with this type of things. They are independent because they have to develop the sense of independence because they have to spend more time at home and sometimes alone. There is some role confusion. You know, are you my doctor or you are my parent? Some of these kids sometimes tell me, making fun, that I don't know what is to go to the doctor. I have my father at home. He tells me what to do when I cut myself or when I have a stomachache. And there is a model of sacrifice, okay? Something that is beautiful to see in all medical families is you always, you know, at some point is something that as a therapist always touch me, is this sense of serving others. I don't know, I really think that this is before the medical school, but something that I see in all the doctors that came to my office and makes everything more beautiful is to see the sacrifice, the model of serving others that they have. It's really difficult to find a doctor that they don't have it. In some specialties, you can find some people that you can say, I am not so sure. But most of the time, this model of sacrifice makes you as a therapist feel that you are doing the correct thing, trying to help them. And something that happened with most of the children is that you never are going to believe any medical TV show again. A lot of children of doctors told me that. So some of the voices of children. As a child, my father, a surgeon, was almost never at home. To see him was weird, almost a privilege. I stole his stethoscope to have something of him close to me when it was difficult to sleep at night. I don't want a doctor, I want a mom. What is more important to you, your patients or me? Okay, so here we have Laura. Laura is saying medical physician's daughter here. Great to know. Thank you, Laura, for that. There are also a lot of pressure between the context. In my small town, everyone knew Doc Schwen. Sorry if I am not pronouncing correctly, Laura. Sorry for that, but you can see that my perfect Wisconsin accent doesn't work so well all the time. Your behavior could bring shame or to your family or price. And poor behavior or poor performance were not acceptable. A strive for excellence was certainly a mantra in my house. This is so true, Laura. Most of the times when I do the family therapy, one of the first thing that I try to focus on is to try to show these parents that, you know, kids are kids. Wherever you are a doctor, that you have a kid, or you are another type of profession, or whatever you do in life, a kid is a kid. And sometimes, yes, it's true that there is a potential more pressure in these families. I completely agree with you. Yeah, and it's something that takes some time to doctors to understand, but is an incredibly good point. I agree. Oh, thank you for that with my accent. So what is going on with our doctors? Let's see what is going on with our doctors. Let's see where all of this starts.
I solemnly pledge to consecrate my life to the service of humanity.
I will give my teachers the respect and gratitude that is their due.
I will practice my profession with conscience and dignity.
The health of my patient will be my first consideration.
I will respect the secrets that are confided in me, even after the patient has died.
I will maintain by all the means in my power
The honor and the noble traditions of the medical profession.
My colleagues will be my sisters and my brothers.
I will not permit considerations of age, disease, or disability.
Creed, ethnic origin, gender, nationality,
social standing, or any other factor
to intervene between my duty
and my patient.
I will maintain the utmost respect for human life.
I make these promises solemnly.
I make these promises solemnly,
freely,
and
upon my honor.
So look the last part. To dedicate your life to serve others. Okay? Dedicate your life to serve others. And what others expect of you if you are a doctor? It's a plane. No, it's Superman. No, it's Super Doctor. What's happened with us as patients? You know, we don't accept that doctors are human. We don't actually want to see them as human. And nothing that is less than perfection is accepted. If a doctor made a mistake, it's something that is, you know, penalized, not just for the environment where they are in, is also penalized by patients, is penalized by society, is penalized by boards, is penalized everywhere. So this makes the cultural part of the medical culture values extremely difficult to fulfill, you know, because if you are a super doctor, when you have time to be a human being. So I remember last time, the first time that I was working with a resident, and he told me this phrase: see one, do one, teach one. On top of the expectations that we have as patients, societies, health systems, governments, and everyone, what doctors, when they are in medical school, they have to learn pretty fast. And it's not that they have to learn just a small you know, amount of content. They have to learn a lot. And in the way that they have to learn it is see one, do one, teach one. It's not like, at least myself, I need to see at least 15, do at least 150, and then probably I can teach one. But doctors are not allowed to that, okay? Once they see one, do one, they have to teach one, okay? So just to try to understand a little more what's happening inside the medical culture. The burnout epidemic, 63% of doctors reported stress and burnout during 2020 and 2021. Of course, we have to think as a control factor COVID. But either way, before before COVID, we were also in 50% having these numbers. 55% of doctors at this point are considering to leave the medical profession in the next 2 years. Why? Lack of life-work balance is one of the first things that they say. Second, unrealistic demands. Yes, of course, completely unrealistic. We expect of them to be really Superman. And the big problem is that most of the time, some doctors believe it, that they have to be super doctor. And the last one is we have to talk that healthcare is under trouble, you know, in all the nation. Is really difficult to find a healthcare place that at this point is not having some toxic, dynamics. So corporative medicine brings a big paradigm conflict, you know, because as we saw in the last documentary, doctors really go for this profession for patient care to serve others. But corporative medicine, on the other hand, brings the paradigm of more profit maximization. So these two values collide and collide really badly. And I think that in big part, this is what is bringing a lot of problems to healthcare. There are two values that they are in constant confrontation. You know, doctors want to do more for the patients, but there is another system that in some aspects have more power than doctors that is not allowing them to do all what they want and what they can for patients. While burnout manifests in individuals, it originates in systems. Okay, so it's not that doctors are stressed out because they want. Okay, no, they are stressed out because contexts where they have to interact are very toxic a lot of times. So what's happening in the healthcare system? You know, as we spoke, they are chaotic systems most of the time. Relationships are not easy. We find more conflict than any other thing. We see a heavy individualistic perspective where you have to tough it up, you know, okay, but I have 20 hours without sleep, tough it up. You have to see 30 patients, tough it up, you know, okay, but I need something for me, no, tough it up, you know. So in the same way that this fantasy that we have super doctors and we believe, or what we as patients want to believe that this fantasy is true, the same system, but in one way or the other, is asking them to fulfill this fantasy that they are super doctors. So there is an important, you know, tendency in healthcare systems to be handled by business and legal orientations, more transactional type of orientation, and there is not so much space for emotional processing. Actually, sometimes I just do this exercise with a lot of doctors that work with me, and they always tell me, stop being a shrink. You know, I stop them and I ask them, okay, what do you feel? You know, what do you feel? Just stop here. Stop all your logic. I know that all of you are extremely smart, but just tell me in a couple of words, what do you feel? And sometimes it's really difficult for a lot of doctors to articulate that. So Lara is saying this is true. Our systems are set to drive out the compassionate individual patient care, which is why the docs went to medical school to begin with. Exactly, there is a huge value conflict here. Their values cannot be lived out in corporate medicine context, which inevitably leads to frustration and feelings of ineffectiveness. Yes, I agree. And also going just one step forward, that we're going to talk more about that now, this brings moral injury. Moral injury, perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply moral held beliefs and expectations. This is I see that with doctors all the time. You know, the insurance of one patient is not allowing them to have one medicine, and they have to prescribe one that they know that is not so effective. Or they cannot perform the surgery that they know that the patient needs because the one insurance or the other is not covering that. Doctors are exposed to moral injuries all the time. Just to 1 minute to explain what moral injuries is in terms that was developed for the military when soldiers have to do something that was against their values and they suffer this type of consequences. Moral injuries try a lot of psychological problems. Not so many options for non-profit work for doctors, okay? Private practices involve more administrative work than to work for the health system. And for primary care health centers, generally involve high number of patients. So there is a lot of challenge for primary care doctors to develop still longitudinal relationship, that this is something that most doctors working in primary care, they want to do. This is why they go to primary care. As a result, it's really difficult for doctors today to find joy in the job. So a couple of things now we're going to talk. I know that I just have 10 minutes. I'm going to go a little faster now. I didn't know that I put so much material. This always happened to me. It's part of my imposter syndrome. I am always afraid that that material is not going to be so much. So sorry that I put so much material, guys. So in the family assessment, be careful about monopolization of talking. Some doctors, they are very smart and they go very fast in the think process. And most of the time, you're going to find that some doctors try to monopolize the discourse. We have to be really careful of that, because once they said the first premise, they take it as true. When they go to the second premise, all of that, they believe that you already got it, that all what they said is true, and stop there. And then they want a solution, okay? So what's happened is that we have to start thinking in a little more circular ways with doctors and try to start putting more elements of emotional connection, because if not, what you're going to find is that you are talking about logic all the time. So try to understand the moral standard of the family and try to look for assessment of these moral standards in the rest of the family, okay? Try to define or understand what support means in these families and experiences of loneliness in the doctor, but also experiences of loneliness in the rest of the family. So we have to try to also see what is lost in each time of the family cycle related to the medical cycle of life, okay? Most of the doctors move from one city to the other for medical school. They move again for residency, and most of them also move again for work. This implies for the family losses in friends, family losses in always being in the same neighborhood or going to the same school. So it's really important when we are seeing about the family cycle to try to understand what is the cycle of losses as well, okay? Dr. Webb, he's one of my heroes in YouTube, and they asked Dr. Webb, what is more challenging, military training or medical school? He's a surgeon and he's also a veteran. And he said, by far, it's more challenging medical school than the military, okay? The amount of expected knowledge acquisition is almost impossible for a normal human being to absorb. Okay, someone that was in the military and someone that did medical school. An ex-veteran said, it's easier to be a military person than to be a doctor. In residency, okay, we finished medical school. Now we go to practice. Now I'm going to have a salary, a very small salary, but at least I'm going to have a salary. So people think that now that they're going to have a salary, life is going to be a little easier. No, it's not necessarily the truth, because the same level of pressure and challenge that they see in medical school is going to happen also in residency time, but they have some payment. Some interventions, okay? Addressing the higher moral value, okay? The doctors take the Hippocratic Creed doesn't mean that the rest of the family took it. So it's really important to understand where the rest of the family are in terms of that. because if we don't see that, we are going to take for granted that what is the moral standard of the doctor is the same of the family, and most of the time it is not. Circularity is a must, okay? When we see this type, you know, when we have a doctor in the family, the effects of being a doctor is for all the family. It's not just for the doctor life. So we have to be really careful about what we can understand as the multi-level causation of doctors in families. Let's talk about vulnerabilities. And after the first time that we spoke about vulnerabilities with doctor, let's talk about that again. And after the second time, again. And after that, again. And after that, again. And basically make, to talk about vulnerabilities, a theme of each session. Okay? And something that we have to be a little detectives, okay? Try to identify emotions. There is a tendency to a hyper-logical scientific type of conversation that is short, to the point, and with minimal post-development. Address the role of emotions in developing healthy attachments for the family and relationships. And after some time of attachment work, you potentially will see a change in the attachment style. So, you know, I like to open that to other psychology students that I am talking about that. But most of doctors, when you see them initially, they are going to look as very avoidant in the attachment style. This doesn't mean that really they have an avoidant type of attachment style. It's what they are trained for during all the medical training, okay? They have to be a little more avoidant because there is no space for emotions in their lives. So to reconnect them with emotions, probably at some point you're going to see a change in the attachment style. So here Rylan said, so glad you are talking about moral injury. I think we tend to just talk about burnout, which often conveys the idea that individual needs to the fixing of applying more self-care. Moral injury, however, can show how systems in place often cause the dissonance with values and actions resulting in mental health symptoms. Excellent point. The more that we expose our doctors to contradictory values like this, we are going to have no 63% of doctors burnout. At some point, all of them are going to be burnout. So, you know, the moral injury as a consequence of all of this amount of stress and injuries that they are exposed all days to suffering, you know? So still I didn't make any point during all the talk today, but, you know, still that we are asking them to disclose in applications to state boards or to credentialing if they had a mental health diagnosis before. I personally think that is just crazy. You know, we have to do more lobby. We have to do more support of our doctors. We have to be there showing them that they are human and that we understand that they are human, because they are such an important piece of our societies and communities. So with that, I want to thank all of you. And I think that, Tyler, if I am right, we have 2 minutes for questions or feedback or for whatever people want to say. I'm right?
Correct, yes.
Okay. So I want to open the mic if someone wants more references or papers. I think that at this point there is not so much research really about this. So I am happy to send you over whatever I have.
This was very interesting. Thank you.
Laura.
Yes, thank you. It was excellent.
I appreciate that.
I think I missed at the beginning. Are you sharing the slides or the video with the participants?
Yes, of course. I'm going to send it to Tyler. And Tyler, you just, you know, I am very happy to put all of that in there. Do we have any type of drive or something in CFHA to share all of this, or I shall send it to you, Tyler?
No, this will definitely be posted and distributed with the video recording and the slides. Hannah does that.
Yeah, I'll be posting it on YouTube. Tyler, if you can forward those slides on to me, I'll include them with that.
Yeah, perfect. Thank you.
Perfect. Thank you, Shaki, and thank you, Hannah, and thank you, like always, CFHA, for all the support to these different important things that you are doing and that we have to do more for doctors.